Thank you for joining iMeet. When you hear the tone, you will be the 10th person to join the meeting.
I'm going to start the recording now.
This meeting is now being recorded.
All right, good evening, everyone, and welcome to our monthly AABIP webinar series. I'm Aura Christian from Loma Linda University, and on behalf of my co-moderator, Dr. David Shaw from Harbor UCLA, we're very excited to bring you a highly anticipated presentation by truly one of our esteemed colleagues. But before the formal introduction of today's topic and speaker, I'd like to review a few housekeeping matters. First, everyone please note that this webinar will be recorded. It, along with previous and future webinars, can be viewed on the AABIP website and found under the Education tab on the front page. Now, second, we ask that all participants mute their phones during the course of the webinar to minimize background noise and optimize the overall listening experience for everyone. Alternatively, you can use the volume control icon at the bottom right of your iMeet window. Now, to ask questions or communicate with the group during the webinar, please type them into the chat box. This can be accessed by clicking on that thought bubble icon located in the bottom left of the iMeet window. We usually leave it up to the presenter to answer questions as they appear during the talk, so please feel free to type in your questions throughout the webinar. But we will keep track of the questions as they come up and address any leftovers at the end of the hour in a formal Q&A period. Now, also on the bottom left is a projector icon. This allows the audience to toggle between the presenter slides and any videos, although I don't think we have any videos in today's presentation. And finally, a couple important disclaimers. The AABIP does not endorse any specific technologies or products. Also, the content and views expressed within the webinar represent the opinions of the speaker and do not necessarily reflect those of the AABIP. So without further delay, please allow me to turn things over to Dr. Shaw for our formal introductions today. Dave?
Thank you, Aura. Today we are very fortunate to have Dr. Tim Murgu join us. For those of you who may not know Tim, he is a prolific speaker and very experienced on our topic today. He comes from the University of Chicago, where he is the program director of their IP program there, and he also happens to be our AABIP Secretary-Treasurer at the moment. So I would like to thank Tim for speaking to us today on the topic of non-malignant central airway obstructions. Thank you, Dr. Murgu, for joining us.
Thank you, Aaron. Thank you, Dave, for the kind introduction. I hope everyone can hear me well. I'm using one of the desktop microphones. If there is an issue, let me know now so I can reset it. So it's really a pleasure. It's the first time I'm doing this, and I'd really like to make it more of a dialogue than me having a monologue and wait for questions at the end. I hope people by that time won't really be too tired out. So I figured let me start with disclaimers. First of all, many of the pictures you'll see in this talk are from a textbook that Henry Colt and I published a few years back. There are some others that are not in the book, which are more recent cases. For the purpose of being efficient, I did not include any videos. In terms of other disclaimers, I do education for several device manufacturers. I personally don't think those conflicts are relevant to this lecture, but you'll decide on your own later. So this is my outline for tonight. I figured common language is in order, classifications and clear definitions are in order when we talk about airway obstruction in general, and specifically actually for benign airway disease, where there are way too many terms used in the literature, and they can get confusing. And then after we review the classifications, I want to focus on certain disease states, mainly relapsing polychondritis, GPA, but most of the talk will really be on strictures, post-intubation, post-tracheostomy, and idiopathic stenosis. And then ultimately, we'll talk about treatment with a focus on laser and electrocautery-assisted mechanical dilation for those patients who are not surgical candidates. So, classifications. You may or may not know, but there are several classification systems proposed in the literature, mainly by our ENT colleagues. McCaffrey is one that staged the laryngotracheal stenosis, which is actually the preferred term, because many of these strictures involve not just the trachea, but also the larynx, and often they actually extend from the larynx to the trachea. So McCaffrey, after reviewing 10 years of his experience, proposed this classification system in Laryngoscope 1992. I invite you to review this paper. He looked at the ultimate outcome for decannulation. So all these patients were actually trached, they had an indwelling tracheostomy, and then he defined the extent of the problem and correlated that extent with successful decannulation. So you can see in this diagram, stage 1 would be isolated subglottic less than 1 centimeter. Stage 2 is a stricture that's longer than 1 centimeter, either is a subglottis or trachea. Stage 3 is one that involves the larynx and the trachea. And then stage 4 is an interesting one, which you may never see, because these patients usually end up seeing in ENT docs. And that's the picture that I have on the top right. That is a stricture that actually involves the glottis. Now, the glottis is defined as the space at the level of the vocal cords and 0.5 centimeters below it. So if there is a fibrotic band that goes a little below the vocal cords, you're still in the glottis. And a reminder for everyone, in subglottic space is a space between the cords and the cricoid, and that's still a laryngeal abnormality. So this is the McCaffrey proposed by ENT, used by ENT docs, and it's referring to the extent of the stricture. Now, in terms of severity of the airway narrowing, there is another system, Meyer-Cotton. I believe the paper was in '94. Meyer and Cotton defined the severity of the narrowing based on 3 cutoff values, the 50, 70, and 99%. And you may say, how can you have a grade 4 stenosis with no lumen? Again, these are patients that had an indwelling tracheostomy tube. So there are cases of absolute, complete, 100% obstruction above the stoma. So they also looked at the outcome for decannulation. So not surprisingly, the less severe degree of narrowing, the more successful the decannulation. What I found interesting is that they actually used the cutoff values of 50 and 70%, which are actually numbers that are physiologically justified, as I will show a little later. Okay, how about pulmonary ducts? Lutz Freitag, Armin Ernst, very well known in the IP community. A few years back in Europe, the interventional pulmonology course, they surveyed physicians and they got together and they tried to propose a system for tracheal stenosis. And the system is quite complex. If you want to read this paper, it's in ERJ 2007. It does refer to mechanisms of obstruction like extrinsic compression, intrinsic obstruction, dynamic features, and then they also describe the degree of narrowing. Now, in regards to the degree of narrowing, I found that the values that they use, 25% and 26%, they're not necessarily based on impact of flow, dynamics, or physiology. So, to my knowledge, this is not a commonly used classification system, but it is available out there in the literature for you to review. All right. The way I look at airway narrowing, in general, not only for benign, but in general, I like to classify it based on what I call qualitative criteria. That's, first of all, what's the histologic type? Is it malignant or benign? I look at the dynamic features. Is it fixed or dynamic, namely during the inhalation or during exhalation? And then the mechanism of obstruction. Is that extrinsic? Is it intraluminal or a mixed process? These are all qualitative criteria. And then you have the quantitative ones, which can be objectively described, such as severity of narrowing, and one can do that based on the CT scan measurement or using bronchoscopy if you capture images and then analyze the images using software image processing. Then extent of the narrowing, that can be measured with a bronchoscope as well, and it becomes very relevant to treatment. And then ultimately, not every airway abnormality needs treatment. Many patients have stenosis that we detect incidentally. So we should try to objectively define the impact of the severity and extent on the functional status and symptoms. So, in regards to that, I invite you to look at this diagram with me and spend 1 minute trying to understand it, because it's one of the papers that looked at computer-simulated flow through tracheal stenosis. It was published in Journal of Applied Physiology about a decade ago. So on the vertical axis, you see the pressure drop from the point 0, which is, let me use an arrow here, from the point 0, which is right here at the top left. That's the glottis, and then these numbers on the horizontal axis represent millimeters away from the mouth. So look at the squares for a second. Those squares represent the pressure drop through the vocal cords. The circles here at the top of the image, my arrow doesn't work. The circles here represent the pressure drop through the 50% tracheal stenosis. So in reality, the vocal cords, the glottis, really behaves like a 50% airway narrowing. And you know that when you pass the vocal cords with the bronchoscope, the trachea opens up. If you calculate the cross-sectional area at the level of the glottis, that's about 50% of the normal tracheal diameter. So in reality, a 50% stricture, or less than that, should not really impact flow. The more severe it is, the more significant the pressure drop will be, of course, and therefore more work of breathing. The length of the abnormality will increase the resistance to flow and pressure drop, but not as much as the severity. For instance, to justify that statement here, to explain it, you'll see here all these narrowings of 90% stenosis. One was 1 centimeter in length, the other one 2 centimeter, 3 centimeter, 4 centimeter. There was some increase in the resistance, but not that much. So severity of the narrowing definitely impacts flow more than the extent. We need to be precise in defining the extent. That has to do with operability, if that segment of the trachea or the larynx can be removed surgically, and it has to do with your selection of a stent. But in terms of flow dynamics, the extent is not that important as severity. All right, this diagram, it's basically just illustrating that the pressure drop becomes significant when the narrow airway lumen is usually narrow by 70% or more, unless you exercise, in which case you look at these circles. Those circles are simulating flow 30 liters per minute, in which case if you exercise, even a 50% narrowing will result in a high pressure drop. So what do I learn from this? Just like the coronary disease, you know, when you have a mild narrowing less than 50%, you may not have symptoms at all. 50 to 70%, those are patients who usually become symptomatic with exertion. And then the severe one, you may actually have patients that have symptoms even at rest. Okay, so that's severity of the airway narrowing. But what we learn in time is also morphology. The shape of the stricture actually impacts flow, which is not something that's captured by equation. If you look at the equation that I have here with the delta P being dependent on the flow velocity through the narrowing at the power of 2 and the radius at the power of 4, that does not account for the morphology or the shape of the narrowing. But in computer simulation studies, in flow simulation studies of tracheal stenosis, it appears that the shape of the narrowing actually impacts that pressure drop as well. With the circular or circumferential stricture dropping the pressure more than the triangular stricture, right? Like right here, you can tell the triangular one doesn't drop the pressure as much as a circular one for the same degree of airway narrowing. So the cross-sectional area is the same, However, the morphology will impact flow more if you deal with a concentric circumferential stricture. For those of you who see post-intubation and post-tracheostomy strictures in your practice, you know that is true. That's something we observe. We bronch patients sometimes for a BAL, and we notice a post-tracheostomy stenosis, a so-called lambda or A-shaped or pseudoglottic, because it really looks like another set of vocal cords. All those terms have been proposed in the literature for this. And sometimes we see narrowings of like 70%, and patients may not be that symptomatic. So practically speaking here, when we see a stricture in the airway, we should try to be precise in describing the shape as well, the degree of narrowing, and its vertical extent. In regards to morphology, good luck finding consistency in the literature. A few years ago, we published a review article, and I can tell you I was fascinated to see how many terms people have used for describing the same abnormalities. I just mentioned to you the pseudoglottic stricture, and again, that's known as triangular, A-shaped, or stomal stricture, or lambda, and all those are describing basically the same thing. So unfortunately, we don't have a unifying classification, and that will become relevant when we talk about performing meaningful research in benign airway disease. All right, in terms of mechanism of obstruction for non-malignant CAO, just like with malignant, there will be cases of extrinsic compression, and they are listed there. Endoluminal exophytic, and that's really the polypoid abnormalities, that's not cancer. And the differential is on the slide with the most common ones. But then ultimately, what I like to spend the rest of the webinar on is the actual stricture. And the dominant one, the recurring diagnoses there are idiopathic post-intubation, and then some of the connective tissue disorders. I will not talk about post-TB and post-transplant. All right. So this may not be an uncommon scenario in your practice. Someone who has asthma for several years and then ultimately gets diagnosed with a tracheal stricture. This particular case was someone who was intubated, survived ICU after a car accident, gets extubated, and gets diagnosed with asthma. Unfortunately, for a while, people were only looking at her office spirometry, which showed obstruction, until full PFTs were done that showed a classic square pattern or hamburger effect, as you may want to call it, suggesting a severe tracheal stenosis. This was a mid-tracheal stricture, suggesting that he's likely post-intubation. However, one never knows. Maybe it was there to begin with. Maybe it was idiopathic and it was just made worse by the intubation. Or maybe it's related to connective tissue disorders like GPA or relapsing polychondritis. So that's really what our job should be. Based on a good history and maybe some serologic studies, we should try to define if the stenosis that we're seeing in our patients, laryngotracheal stenosis, if that is idiopathic or it's secondary to some prior injury or connective tissue disease. I do want to point out that reflux is involved in both processes. If there are a couple of studies that already looked at pH measurements in the posterior nasopharynx, and the pH is less than 4, both in idiopathic and in secondary stricture. The question that we don't really have the answer yet, but it's part of our practice. Many of us are doing that in these patients. We do the PPIs or any other anti-reflux methods have an impact on the disease process and disease course. I'm aware of a couple of case reports where prior to PPI treatment, patients had frequent dilations. Once the PPI was started, the time interval to recurrence to further procedures was increased. So maybe the inflammation from reflux is contributory, and placing patients on PPI may reduce that recurrence rate. I know several centers place patients on PPIs twice a day, and that is to take it like 30 minutes to an hour before dinner. Some people even put patients on Bactrim and inhaled steroids. Again, that comes with a very weak evidence. So, yes, on the slide you see the differential diagnosis. Again, idiopathic, secondary to post-intubation, post-tracheostomy, autoimmune. But I do want to briefly just mention that in endemic areas of tuberculosis, about 8% of tuberculosis is endobronchial, and unfortunately many of those patients have caseating type of TB. And if that's the case, there is a very high rate of tracheal stenosis post-tuberculosis. In people coming from Mexico, there is something called Klebsiella rhinoscleromatis, Central America, Mexico in particular. And in some patients who survive ICU, just as MRSA or staph necrotizing tracheitis can eventually heal with a stenosis. So infectious etiologies can lead to benign strictures as well. Okay, moving on. My challenge in the practice is how do I know if this is actually a complex stricture, like one that would be post-intubation, or is it an idiopathic one, in which case typically the cartilage is completely intact. To the naked eye, as you can see on the white light bronchoscopy pictures on the left side, to the naked eye, sometimes it's hard to know if the cartilage is broken because the fibrotic stricture covers everything. So with the radial ultrasound, and this is the balloon-based ultrasound, which very few people use these days, including myself. We have it but rarely use it. But with the radial probe ultrasound, you may get an idea about the nature of the cartilage. In a idiopathic stricture, you can clearly see the cricoid cartilage and then the fibrotic tissue, as you see on the EBUS image here at the top middle panel. While in post-intubation, where the cartilage may be broken or dystrophic, there is actually a defect in the cartilaginous ring. And we know that from surgical specimens that have been resected that in idiopathic subglottic stenosis, the cartilage is completely intact. That's just a proliferation of the submucosa, while in post-intubation, usually the cartilage has been damaged. Definitely in post-tracheostomy, but in post-intubation sometimes as well. That's why many of the post-intubation strictures are actually complex and typically don't respond to dilations. Eventually you require either surgery or a silicone stent placement. All right. I will not spend a lot of time on this, but again, definitions and terminology, clear terminology is in order. And I invite you to just take a look at these images and think about, okay, which image is actually simple and circumferential, and which one is complex and pseudoglottic, or the other two choices that you have. And we're not going to vote for this, but just eyeballing this, you can tell that the image at the bottom, it's circumferential, that's pretty clear, and it surely looks like a web-like stricture. Now, you need to pass the bronchoscope through to see if it's truly less than 1 centimeter in extent, because that's usually how we define a simple stricture. And that image at the top, it clearly looks pseudoglottic, or the triangular type, likely related to post-tracheostomy. But what's also interesting there, it actually involves 2 cartilaginous rings, so it's multi-level. Complexity, by the way, is defined based on extent greater than 1 centimeter and cartilaginous involvement, or cartilaginous involvement. And why do we care for defining strictures as simple or complex? Because the simple ones, again, without cartilage damage and less than 1 centimeter in vertical extent, they can be cured by surgery, or they respond very nicely to bronchoscopic dilations assisted by laser or electrocautery knife. The complex one, where there's fibrotic tissue in the actual tracheal wall and cartilaginous damage, or if the stricture is long, they typically don't respond very well. Only about 30% of patients respond to bronchoscopic dilation, 1 or 2 dilations. So these are the patients that typically should be referred to surgery for a tracheal sleeve resection if they are surgical candidates. If they are not, then a silicone stent can palliate their symptoms. So complex post-intubation stenosis is not that uncommon, but the minority of patients are actually symptomatic. Again, complexity defined on extent and cartilaginous involvement. All right, treatment. Should I take a break, guys? I mean, we've been speaking now I have gone through 30 slides. Should we address some questions now? I'm not seeing the questions yet, but Era and Dave, if you took some notes for questions, how about we talk about some of them now?
No questions at this in time that we've accumulated,
no.
So
okay.
Probably best to continue.
Okay. If the audience has questions, please write them down so we can address them either now or at the end. Because as I said, I like to keep this somewhat of a dialogue, not just me delivering a talk, which you can probably download later and view at your own pace. All right, so let's move on then. All right, so treatment options. Sleeve resection, that's a surgery, open surgery where the surgeon cuts above and below the narrowing and does an end-to-end anastomosis. Works very well for simple strictures that are not that long in vertical extent. And by that I mean anywhere in between 1 and 4 centimeters. Some surgeons operate on strictures that are longer than 4, like up to 5, but that's pretty much it. Because if the strictures are too long, then taking that segment out, there will be a lot of tension at the anastomotic site, and that can result in dehiscence or recurrence of the narrowing. In experienced hands, though, guys, I want to point that out. It's clear from the literature. In experienced hands, what I mean by that is people who do tracheal surgery for a living, the recurrence rate after a sleeve resection is about 10%. 10%. So we have to always decide on what do we want to do. Do we want to mess with that narrowing with a bronchoscope over and over and over again? Or do we want to have an experienced surgeon operate on your young patient without any comorbidities that it happens to have an idiopathic subglottic stenosis or had a bad luck of getting a post-intubation tracheal stricture? Now, that being said, the very simple strictures, the ones that are web-like, less than 1 centimeter, 1 or 2 bronchoscopic treatments may actually result in lack of recurrence or recurrence that's not symptomatic in 2/3 of patients. I'm talking about, again, only the web-like ones. Dr. Atul Mehta from Cleveland Clinic showed that in the 90s. Laser-assisted balloon dilation of web-like strictures, cure rate, so lack of recurrence in 66% of patients. So I would say a stricture like that, sure, like the one in the image here, I would try once or twice, and if it recurs, surgery from the very beginning. The complex ones, which we're gonna fail just with bronchoscopic dilations, we either refer them to surgery for resection, or if they're not surgical candidates, either because they are too long or patients have too many comorbidities, then they should get a silicone stent. This slide summarizes the usual criteria for operability. Again, strictures that are up to like 4 to 5 centimeters. The ones that don't involve the larynx. Now, they involve the larynx. There is a type of surgery, laryngotracheal resection, where the cricoid is removed as well, and that tends to be more complex. And then usually surgeons like to operate on a stenosis that's either idiopathic or post-tracheostomy, post-intubation, not the ones that are due to connective tissue disorders, because those could obviously recur once the disease flares up. The length of stay for a procedure like this is about 2 to 3 days. I know of centers who send patients home like the day after. In this case, you see a short segment was actually resected. and there was minimal stricture at the anastomotic level, not significant at all from physiologic standpoint. So if we can cure the patient with a open surgical resection, I would suggest we do that and refer patients for an expert surgical opinion. If that expertise is not available, or patients have too many comorbidities, like someone who survived ICU and now they have post-tracheostomy stricture, that's when we address them bronchoscopically. Now, for those of you who use laser, for the laser-assisted dilation of the laryngotracheal strictures, the typical lasers that should be used are either CO2, very familiar among ENT doctors, or KTP. And the reason for that is these two lasers are, their effect is very superficial. I'm talking like 0.1 to 2 millimeters or so. And they are great in cutting, but they are not coagulating very well, which is actually what you want. You want a great cutting tool, not a coagulation that may result in collateral damage. So when I hear that sometimes people use Nd:YAG for a benign stricture, I worry that the collateral damage that's classic for Nd:YAG, which is great when you want to coagulate a tumor, it's not good when we deal with a benign stricture because of that thermal damage to the normal mucosa, which may actually lead to recurrence. A quick reminder, when we use laser, the actual effect of the laser in terms of depth, the ones that people cite in the literature, that Nd:YAG goes to 1 centimeter, KTP to 2 millimeters, CO2 to 0.1, etc. Those are numbers that come from experimental studies, but ultimately the effect actually depends not only on the wavelength of the laser, but also on the tissue color, and that's illustrated here. A red shiny lesion, even for Nd:YAG, the effect won't be deeper than 1 millimeter. So please take a look at those numbers cited in the review articles and in presentations. Take them with a grain of salt. They're not always accurate. All right, this image here, I want to illustrate two technologies that, in my opinion, have pretty much a similar effect. This was actually done by, it's a recent case that we had. Well, my IP fellow did this. You see an incision at 5 o'clock. That's with a KTP fiber. And then one around 7 o'clock. That's with the electrocautery knife. In my visual inspection, they are about the same in terms of thermal damage. So I don't know what tool to use. All I know is that we want to make a precise cut without too much collateral damage. We don't want to coagulate this in a circumferential way with a lot of thermal energy. This is not treated with argon plasma coagulation. This should not be treated with the Nd:YAG laser. And unfortunately, there are no studies that are actually comparative trials where an electrocautery knife was compared with the KTP laser. They just don't exist at this point in time. So what other things can we use? I came across this paper in preparing this lecture, and I only show it because I was perplexed by the images. So these authors used contact cryoprobe followed by dilation. The bottom left image, bottom right, I'm sorry, image D, shows the post-dilation effect. And that was considered by the authors to be a success. And maybe, and I suspect after you use a balloon, the airway will be bigger and people will feel better. But to my naked eye, that image shows quite significant mucosal trauma, which, again, a reminder, we know that mucosal trauma, if it's mechanical or thermal, those two factors are independent risk factors for recurrence of these strictures. So I don't know about this technology until we have more data. The one that's actually interesting, and there may be a role for it, and full disclaimer, I do not have this technology, but I hear lectures on it, and I've seen papers on it already. One comes from a thoracic surgeon, Faisal Bora from New York, and he got it published in JAMA on ENT. So I think it's a credible manuscript. You can look at this case series, 26 patients. Some of them had GPA, some were post-intubation. Apparently, they failed conventional treatment. I forgot what that actually meant. I suspect was some kind of dilation. And then they used the cryo spray. And it looks like most patients received about 2 procedures. This was done either with suspension laryngoscopy or with a large endotracheal tube. And they had a follow-up of almost 1 year. And from 90% of patients having grade 3 and 4 stenosis, after these treatments, only 15% of them had severe stenosis. In fact, the GPA group apparently had even fewer procedures. So there may be a role for this. They report no intra-op complications with this cryospray, which apparently was a concern in the past because of barotrauma and pneumothoraces. And again, full disclosure, I'm not familiar with this technology, but it does appear there may be a role for it. What I do not understand, though, is the mechanism of action here. So all these patients had cryospray followed by dilation. So I think the fundamental question is, how do we know that cryo actually added anything? Maybe the hemostatic effect, but do we know if there is an additional benefit from it or not? So I mean, the prospective study just comparing cryo with dilation versus dilation alone, I think will clarify that. In addition, traditional teaching, conventional wisdom tells us that these fibrotic strictures are actually resistant to cryo treatment. They are not rich in water, so I will need to learn a little more about it and see more papers until I personally implement this in my practice. Laser-assisted dilation works. Immediately, it will open the airway. There may be, again, recurrence. Here you can see when it was really narrow. That's a complex stricture on the CT scan. It opened up. The flow volume has improved. Not perfect, but has improved. But then weeks later, it actually came back. As I said, older studies from the European colleagues, Cavalieri and Pablo Jimenez and François Dumont, if you look at those papers from the 90s, about 60 to 70% of patients with post-intubation stenosis who have complex stenosis have recurrence. That's when you end up placing a stent in those people who are not surgical candidates. So in terms of stents, the stents that should likely be used are the silicone stents, because we know with the metal ones, for a benign process, for patients expected to live longer, we may be looking at severe complications. Now, there is a lot of talk recently about looking again at the newer generations of metallic stents, and I kind of agree. I don't think they are as stiff as they used to be, and I do think we use more judgment in inserting metallic stents. However, there is no strong data to date to actually use metallic stents for this disease. I'll come back to that in a second. Silicone stents, although they are of choice for these problems, they can cause complications as well. They can migrate. Like you see in this picture, the stent was sitting nicely on the carina, but it did its job in opening the airway. What's fascinating, we learned that in time, a stent dilates the airway and the cartilage may actually regenerate. So there is some remodeling locally. And if you look at the original paper from Dumont, after he had a stent in place for 18 months, about 20% of patients had the stent removed and did not require another stent. So it's very likely that there is some cartilage regeneration. And now we're learning also from those studies with the aortic grafts from brain-dead donors that if you do biopsies of the aortic graft, you actually find cartilage from the mesenchymal cells that have migrated in the graft. I think there is a lot of nice work going on. I mean, I wish it was a little faster for us, but what I'm learning from this, if you have a stent in place, it doesn't have to be forever. You may want to check from time to time, remove it, and see if the actual trachea reconfigured and maybe the cartilage regained its stiffness. But they are foreign objects and they can cause problems. Migration is only one of them, maybe not the most significant one. They can also granulate because of too much pressure on the wall, and of course the mucus plugging. Metal stents. So metal stents for benign disease. First of all, I can only think of one potential scenario where I would actually do this. In someone who's not a surgical candidate, and I cannot place a rigid bronchoscope to insert a silicone stent. There may be other ones, they just cannot come to my mind right now. So have I done it? Yes, I've done it. Either fully covered or partially covered, and ideally with very short-term follow-up and reassessment for the need of the stent. If you look at these three references that I have here on the slide, all these papers show that immediately patients felt better, but then short-term and definitely long-term, they all had complications, and authors actually gave up completely using metallic stents for benign strictures. In early 2000s, there were reports of fatal hemoptysis to the point that several IP individuals reached out to FDA, and that's when FDA released that warning about metal stents not to be used for benign strictures. But there is this concept of temporary stenting with metal stents. I've seen papers coming from Boston looking at this for Malaysia, and this paper that I found in Journal of Thoracic Disorders, published 3 years ago, 4 years ago now. They use metallic stents for only 3 weeks in patients with benign stenosis, and then they took them out. And apparently the lung function and the 6-minute walk test was actually improved. So think of it as maybe a dilation, but you don't dilate just for like a few minutes. You dilate for about 3 weeks. Maybe that's enough for the healing process to actually occur around the stent, and maybe if there is some recurrence, it's not that symptomatic. So interesting concept. I think I'd like to see more on safety of this practice before I will implement this in mine. All right. A few words on connective tissue disorders now. So I have a few more slides, a couple on GPA, a couple on RP, and then we'll conclude. The GPA. So GPA involves the airway in about 2/3 of patients. But what I mean by airway, that's from the nose all the way to the lobar segmental airways. Subglottic stenosis is seen about 15–20% of patients. So connect with your rheumatology colleagues, because the airway involvement in GPA is not uncommon. And by the way, when you see a stricture like that and you do the workup, the ANCA antibodies may not turn out to be positive. In fact, even if you do a biopsy, you may not find the classic findings of GPA, because this is usually a scar. It's the consequence of prior GPA flare, but the biopsy may just show fibrosis. So that's where history and close follow-up is in order to actually diagnose this problem. In terms of treatment, the majority will be treated with bronchoscopic interventions. And again, ideally, the less mechanical trauma, although in this picture you see quite a bit of hemorrhage. But I do want to remind you, while sometimes that's unavoidable, we do know that more mechanical trauma and more thermal energy will lead to recurrence. That being said, overall prognosis of patients with GPA, including those with subglottic stenosis, is actually pretty good. And once their disease is actually controlled with the systemic treatment, the subglottic stenosis tends to be controlled as well. There are a few findings on bronchoscopy that may suggest the patient may have GPA. The one that's quite classic or characteristic, I would say, is that yellowish, brownish plaque that you may find on the mucosa, as you can see at the bottom right here. and maybe even in figure A. And then there is something called submucosal bridging. So you literally see a hole going in the submucosa and then entering the airway again distally. So bridging and tunnels. That's also a consequence of chronic inflammation. And sometimes patients may have bronchial strictures as well, not just subglottic. In fact, we had patients that had bilateral bronchial strictures from GPA. How about RP? So RP is really a painful disorder to manage because there is no ideal treatment for it once the cartilage has been destroyed. It can involve the subglottis, and it can also involve the rest of the trachea. In this picture, you see the subglottic airway. It doesn't even look like an airway anymore because it's completely collapsed because the cartilage gets edematous but weak. So there is associated malacia with it. How do you diagnose that? CT scan may not be that useful, but MRI can actually help in defining cartilage edema. The T2 images are useful for that. That's an MRI that was shared with me by my friends from Japan, credited here on the slide, or radial probe ultrasound again. Of note, once the cartilage is involved, unfortunately, many of these patients die with respiratory failure, and steroids do not reverse malacia. So when should we think GPA? Younger patients, more prevalent in women. Typically, they do have a good history for it. Either pain over the neck, when the larynx gets involved, or they have auricular chondritis. So 90% of patients actually report auricular chondritis. And as I said, once the airway is truly involved with the malacia, the prognosis tends to be quite bad. And malacia is not uncommon. Look at that slide. 50% of patients, almost 50% of patients with RP have tracheobronchomalacia. How do we manage it? What's pertinent to us as bronchoscopists? Stenting, tracheostomy, or in mild cases, CPAP. The surgery for this type of malacia doesn't really work. The papers that you read on, it's not that it doesn't work. Nobody tried it, to my knowledge, because the surgery that you read about for tracheobronchomalacia, the so-called membranous tracheoplasty, that involves a relatively stable cartilage, and here the surgeons are suturing a mesh, usually on the posterior membrane, just to bring the cartilage back to a normal configuration, a C-shape morphology. But that doesn't work here because the cartilage is all collapsed and floppy. So when you see papers like this, that membranous tracheoplasty improves symptoms in patients with malacia, that's not for relapsing polychondritis. This usually refers to crescent type of malacia or to sometimes excessive dynamic airway collapse. In malacia, like you see in this picture, for severe cases with respiratory failure, it would be a stent placement. I know people have done Y stents for these patients. Sometimes a Y stent is actually very difficult to insert in an airway that you can barely visualize. In fact, there is a risk for airway rupture. So sometimes we just take one airway at a time. And in this picture, you actually see two stents. One was actually modified and cut to adjust and accommodate to that airway. Not a practice I encourage, but every now and then we have to do it for patients who are in respiratory failure from this disease. So morphologically speaking, though, I do want to point out that there is a big difference between excessive dynamic airway collapse or even crescent type of malacia and the malacia that's due to relapsing polychondritis. In EDAC, the cartilage is totally fine. I personally don't believe that's a disease per se. And then you see just the collapse of the posterior membrane. Now, some people call this malacia, and they may even operate on it or stent it. But that's so fundamentally different than this, where in RP, where the entire cartilage is swollen, you don't even see the cartilaginous rings anymore, and the entire ring is actually collapsing. So just look at the literature carefully and see what disease states authors are actually reporting. All right. I commented on that. So the surgery I was referring to you, that membranous tracheoplasty, when I mentioned that the surgeon sutures a mesh to bring that cartilage back to a normal morphology, that again refers to crescent-type malacia. That's a figure from Grillo's textbook on tracheal surgery. And that group of surgeons have actually published on this in the Annals of Thoracic Surgery in 2006. You may want to look it up. It's the only paper that I'm aware of that actually showed an improvement in FEV1, which is interesting because that means that crescent-type malacia, the one that looks like that when the cartilage is so flat, that's a true tracheal disease. But that's different, though, than when just the posterior membrane is bulging in and the cartilage is totally normal. And those papers did not actually show an improvement in FEV1. Stents for this type of malacia, really quick. Several papers, including ours from 2007. This is Ernst, but we show the same thing with Henry Colt a few years, more than a decade ago. In symptoms are improved initially, but lung function in terms of FEV1, not at all. No paper showed that yet. With stenting. The complications, on the other hand, are not uncommon. So if you decide to implement stenting for crescent-type malacia or for EDAC, not that I recommend it, but if that's what you like to try, just keep in mind to have a close follow-up of those patients, because both our paper and Armin Ernst's paper from the same year actually show that the majority of patients will develop a problem, and that's usually within the first month. And that's actually his paper. The median time to complication was 26 days. That's from Armin, and this is ours. The median time to complication was 29 days in a smaller case series. So while it's not clear that we should follow up patients that have an airway stent inserted, I would say for those patients that have a stent for malacia, I do think there is a role for bringing them back within the first few weeks after the stent insertion to make sure that the stent has not migrated or caused significant granulation tissue. Meanwhile, though, I personally increasingly evaluate these people for response to positive pressure. If they are not in respiratory failure, if they're still outpatients, I try this first, and I brought them on CPAP. The mask that you see in this figure is what I used in the past. Now Respironics, or what is it now, Philips, they actually make a mask with an elbow adapter, and you can easily bronchoscope through that adapter and titrate the pressure up and see how much pressure actually works to keep the airway relatively open. You don't want it too open. You don't want a high pressure because it won't be tolerated, but you don't want those walls, the walls of the trachea, to touch each other continuously with each respiratory cycle, because that's what leads to chronic cough and retention of secretions. So we have not published on this yet, but I have had a gratifying experience with this methodology, with this practice. If you want to read papers on this, it's been done actually in pediatric tracheal bronchomalacia. When infants are born prematurely and their trachea is still floppy, a pediatric pulmonologist will not insert a stent, will not do a surgery, will place the infant on CPAP and allow him to outgrow it. So there is some data in pediatric tracheal bronchomalacia that CPAP does improve symptoms. I invite you to try it because you may be gratified. Of course, it can be used continuously. It makes perfect sense. It's not feasible. But if patients have symptoms mostly at night with congestion or inability to raise secretions, that's when they may see a benefit. It will not improve shortness of breath. It will potentially take care of the secretions and cough. I heard someone saying something. Aaron or Dave?
No, I think that was an echo.
Oh, okay. So that's my talk. These are my take-home messages here. In one sentence, for benign airway strictures, if patients are good surgical candidates, please consider a curative intent treatment, which usually involves tracheal sleeve resection or laryngotracheal resection. If patients are not candidates for surgery, either because of their comorbidities or increased vertical extent, or they have a systemic connective tissue disorder, then try maybe one or two dilations assisted by electrocautery knife or a precise laser. And then if that doesn't work, rather than keep bringing them back over and over again, consider inserting a silicone stent for palliation. Thank you.
Fantastic. Thank you, Dr. Murgu, for truly a comprehensive discussion on a very important and often challenging topic in interventional pulmonology, spanning pathophysiology to clinical practice. We have just a couple minutes left. While we await perhaps a couple questions from the audience, I have a question, and I think actually it overlaps with one of the audience members. My question is regarding silicone stenting in post-intubation tracheal stenosis, and I have, I guess, a couple parts to the question. Number one, do you have a preferred type of stent for these stenoses, i.e. an hourglass stent or other, factoring in perhaps an increased migration incidence? Secondly, what factors do you use to decide on removal? Is it time or some other factors? And then finally, in your experience, what have been your restenosis rates after removal? Does perhaps the type of complex stenosis, such as a pseudoglottic stenosis, confer a higher chance of success?
Yeah. All right, so let me see if I remember all your questions. So in terms of type of stents, there was a time when I worked in California that we tried a few of the other stents, like the hood stent, and but the straight-studded silicone, the Dumont stent, was our the default stent, and it is now the stent I actually use for the rare patient that I have with this problem. So I don't have a lot of experience with the other ones, with the hourglass. I know they've been available on the market. I know people in Europe have used them. To me, migration with silicone stents, and that's my bias, please don't cite me on this because I have no evidence to justify it. I read about this all the time, and I know in studies of malignant disease, they show that silicone stents migrate more than metallic stents. Now, as we all know, right, this community that does perform both stents, that for a properly sized silicone stent, you need an adequate rigid bronchoscope. So if you want to place a 16-18 millimeter silicone stent, you need to have a rigid scope that's 13-14 millimeter in diameter, because you won't be able to load a stent through a smaller scope. So to me, rather than blame the stent, maybe we should think in terms of what's the right technique used for that. When we talk about migration, I sometimes wonder if that is related to the stent itself, the morphology of the stent, or it's actually its size. Now, that being said, I fully agree with you, Ara. I had patients where the stent was nagging. We grasp it with the forceps and we move it back and forth, the so-called cough test. And I thought this will never move. And then they wake up, they take a deep breath, and then it drops on the carina. Or rarely, they actually move up and they cause vocal cord edema. So for that type of problem, different type of morphology of the stent may be useful. I have no experience with that. I can only tell you, in general, a properly placed studded silicone stent tends to do the job. Understanding there are exceptions. In terms of assessment for removal, it is my practice, and that's routine practice for bringing patients for a surveillance bronchoscopy at 1 month, at 2 months. Initially, we actually bring them quite often. And if we see no problem whatsoever in terms of migration, granulation, or thick cemented secretions inside of the silicone stent, then we may increase that interval. On a rare occasion, and I haven't done that in a while now, my practice now it's mostly malignant disease, but on a rare occasion, after about 12, 14 months, we would actually take it out and see if the cartilage has regenerated. Most of the time, though, what happens is like in the picture that I showed you earlier, if that happens, the stent will basically just migrate, will drop down because the trachea is now open. The image that I showed you is a case that I had several years back. And so I think if that's truly the case, when the trachea regenerated from a lambda post-tracheostomy stricture, then that's when you may actually deal with a stent migration. I don't know if that totally answers your questions. I tried to cover the three of them.
It does. That was perfect. There were a couple other audience questions here. I think that you actually already discussed. I think in the 1 or 2 minutes we have left, I'll ask one final question. I've got several GPA patients with multi-level multifocal stenoses that really are quite difficult to manage overall. Obviously, each case is different, but do you have a general approach to managing these patients, specifically how you incorporate dilation with topical application of agents such as steroids, mitomycin C, and so on? And then finally, when you decide on stenting, or is it just individualized?
For which type of stricture? I'm sorry, say that again.
I'm sorry, for GPA patients.
GPA.
Yeah.
Yeah. So I actually had the fortune to take care of a few of these patients in my career. And I've seen them through the course of their illness for many years now. So I reviewed the literature trying to help them out. I reviewed the literature when I wrote the textbook, and then when we wrote the systematic review. I'm still looking to find a good paper on the intralesional injection of steroids. I'm perplexed by how often that's actually being done with almost zero data. Mitomycin C, on the other hand, anecdotally, and in some papers, mostly from ENT literature, it does tend to decrease the rate of recurrence. And anecdotally, I can tell for some of my benign bronchial strictures, actually, it never came back. So I think there is both the literature and my clinical experience do support somehow the mitomycin C application, but not the intralesional injection of steroids. If you guys are aware of more recent papers on the topic, if you found some meaningful data, please go ahead and share it to the community, because if there is a role for this, we should know about it. As I said, I've done it when I was younger, and then I read the literature and I stopped doing it. So no steroids, yes mitomycin C for strictures in general, and the same thing for the GPA. For the GPA, I gotta tell you, for me, if the rheumatology consultants do a good job controlling the disease, if the patient is fortunate in controlling the disease, usually with gentle dilations of those strictures, the airway tends to behave, at least for the subglottic narrowing. In the bronchus, it's a little different, unfortunately. In the bronchus, sometimes with repeated dilations and after repeated flares of the GPA, the bronchus could become alexic, in which case they may require an indwelling stent. Word of caution though, even with the silicone stents, once we place them in the bronchus, like left main bronchus, it may be a long term stent, and revision of those stents could actually be quite dangerous because that airway wall covered now by a stiff stent, may not be normal anymore. And anecdotally, we know of cases that resulted in massive hemorrhage after a silicone stent removal from a left main bronchus. So I would suggest, we stay away in general from these foreign objects unless we truly have no other options. So for a GPA patient, as long as the rheumatologist has no other options, I would say very careful electrocautery assisted or CO2 KTP laser assisted balloon dilations or mechanical dilations.
Perfect. Thank you, Dr. Murgu. Really an excellent discussion for a tough topic. I think we're out of time. Before we close the webinar formally, I want to turn the mic back over to Dr. Shaw for final announcements. Dave?
Thank you, Tim, and thank you, Ara. So just for all of you who are still with us, thank you for joining us for today's webinar. I just wanted to show you on our slide, you'll see the upcoming tentative schedule for the webinar series. In 2 weeks, we'll have a discussion by Dr. Samira Shoje on the usage of tunneled pleural catheters for non-malignant pleural effusions, and you can see the other two upcoming topics for our webinar series. So we really look forward to these great speakers and hope that you can join us for these upcoming talks. Thank you everyone again for joining us today, and have a great evening.
Thank you. Thanks for having me.